Great, so today's session is going to be on the unconscious patient. So you walk into a room and your patient's found to be unconscious. Now, I want to know, first of all, from you guys what you first do in the assessment. Is it the immediate code blue? Or what, do you follow any... You check for a pulse first?
Check for a pulse,
and then okay, so the patient has a pulse. So a pulse in an unconscious patient, what's the approach? What do you do next?
See if they're breathing.
Okay, so what I'm trying to ascertain here is that in your mind, you've got to think of certain processes that are going through and then you check different things. So what could the possibilities be? Hypoglycemia, of course, would obviously be one of the top ones on the list. So you need to do an emergent sugar. Okay. Second thing is...
are they sweating? Are they sweating? If you're low blood sugar, you're usually diaphoretic.
Yeah, it depends on what other co-medications have been given. So that sometimes can be masked, those findings. So in the immediate, so unconscious patient that you've got a pulse in, so you know it's not a cardiac arrest or it would diminish cerebral perfusion. So that's obviously the first thing that you want to exclude is check if there's a pulse there. If the pulse is there, then you know that's their blood pressure, at least if it's a radial. I don't know when you guys check your pulses, it's usually radial then. If you have a radial pulse, you know that the systolic is at least 80. Okay, so remember that 80, 60, 40. 80, 60, 40. So if you can feel a radial pulse, you know the systolic is 80. If you can't feel a radial, but you can feel a femoral and a carotid, then you know that it's at least 60. And if you can't feel the femoral, you can't feel the radial, but you can feel just a carotid, then you know you're dealing with a systolic of 40. Okay, that's just giving you a ballpark figure with blood pressure. So that's a side. So if that's no perfusion going on, unconscious patient, that's a code blue. Patient's unconscious, they have a pulse, peripheral pulse, you probably get a blood, you do immediate sugar. The other thing, big thing, immediate sugar, then what do you do thereafter? So you do your sugar and then you do what does your assessment look like of an unconscious patient? What do you do to them? I mean, do you have a way of assessing? Is there like a protocol you guys follow in terms of assessing them before you do anything? Do you do an assessment? Do you look at their pupils? What do you guys do as the RAs and the nurses? What do you? You're obviously going to do a sugar.
A GCS?
Yeah, GCS, but we know they're unconscious. Yeah, they're unconscious. Vitals, but blood pressure will be fine, pulse will be fine, SATs might be a little bit dodgy because of depending on what their airway is doing.
Keep their airway?
Airway, and then we're thinking mechanisms now of why they've lost consciousness. So the one thing is medications. Which ones do you think are a huge problem?
Opioid?
Yeah. So what would be the clinical signs of opioid toxicity? No? What would you look for opioid toxicity? If they think they're opioid toxic, what do you?
Respiratory rate.
Yeah. So and the pupils would be pinpoint. Hey? Okay. In those instances, if they're on opioids, particularly if they've got renal dysfunction, you can give them like the Narcan. Do you guys have to ask permission to give Narcan or not? You don't have to ask permission. Is that right?
That's my first guess.
Only give a small dose of it that doesn't actually really even do anything. Honestly.
Already. Okay, so that's what we need to look at that thing. Because ideally you guys should be able, because if you think they're on opioids, they've got all the signs to give them to 0.4 to see if they respond.
It doesn't do anything.
Yeah. Okay, but that's at least the point of saying they're unconscious. What other entities would cause a patient to be unconscious?
Well, if you're talking hypoglycemia, then you're talking insulin.
Yeah, well, that'll be that'll be hypoglycemia and all the causes thereof. Seizure disorders? Seizure, what are the clinical telltale signs of seizures?
Petit mal, grand mal.
No, but how would you wouldn't
If they're unconscious and they're laying
you
there
wouldn't have
still,
witnessed it. You wouldn't have witnessed
right.
it. Yeah. So what would keep
Again, we
you
go back to the diaphoresis.
like but sometimes they have blood in their thing, incontinence. Sometimes there's different posturing, like you try and move them, you'll find that they may be still tonic, like the tonic phase of seizures. Another good way to do it is to, if you think they're unconscious, is to take your pen or and just find their feet and just to rub it up on the sole. You've seen dogs do that before. And you'll see the bilateral, the toes will be going up like that. So that will tell you that, yeah, there's probably ABC. You obviously can be calling the dog for help, eh? But this is a way of saying this is a possible seizure. What are the other causes of person being unconscious? So seizure, we've done one. We've done medications. Oh, on seizures. Do you guys know of any medications, and this would be very helpful to have pharmacy do a talk on, any medications you know that lower your seizure threshold, i.e. cause seizures?
That what, sorry?
Medications that actually lower your threshold for seizure. Because we've just done that with opioid, eh? Like if they're having opioid toxicity, or if they're codeine, morphine.
Some of the
Like Dilantin or?
Yeah.
Like Dilantin?
No, that suppresses seizure
Yeah.
activity. I'm talking the ones that cause the seizure.
Some of the
Cause.
psychotropic, like Seroquel.
Ciprofloxacin, big time.
Cipro.
Yeah, moxiflox, big time. Haloperidol, they all lower your seizure threshold. Okay, so again, looking at the medications can assist you about what exactly is happening. And then in our group of patients that we see often, we've got someone on the ICU that'll be coming here shortly. Alcohol withdrawal that also put them at risk of seizure activity. Okay, and of course anybody that's had prior head trauma. So they've fallen on their head and done things like that, they can be prone to seizures, as is previous patients with strokes. So you find somebody that's had a previous stroke, they're unconscious, the question is, you know, have they had another stroke, or have they had a seizure that basically looks, that they've had what they call scar epilepsy. Now, you all know about, one thing I must tell you, that seizure activity is not, we all know the Grand model, eh? All the, you know, there's the tonic form, there's the Grand model, which are your generalized seizures, and then you have your partial seizures. Partial seizures can occur when the patient's conscious, like they're awake and they're doing stuff that's fitting, so that's a simple partial, and then you have what they call complex partial, which is where they're awake, well, at least that you can look like they look awake, they don't have any idea what's going on and they're fitting. And lots of things like that are usually eye blinking, excessive eye blinking, lots of like smacking of the lips, like that kind of thing can be fitting, and then sometimes you can see their hands twitching. But what's important in a unconscious patient that is still seizuring, and you don't know, the best way, there are two ways to assess them. One is you can grab them at the top of their head, like just say, sir, and you can just, or ma'am, you can just put your hands on their masseter muscles here above their jaw. You can feel it, and you'll feel like a muscles going like it, and they're busy fitting. And another classical sign is you can, when you're looking at the pupils for the eyes, when you open your topic, you want to see where the pupils are pinpoint, you'll see them doing this. The pupils going like that, and they call that hippus. Okay? So those are things in terms of trying to find out whether the patient is seizuring or not as a part of being unconscious. Okay? And then you have the group, then you can have people that have had a massive cerebral event that then cause why they're unconscious. So they're perfusing, they've had a cerebral event. Now the question is, what's going on there? Is remember I told you about going up on the pins and the one, so like if you see both feet going up like that, that's usually a seizure activity. That's not a stroke. If someone's going bilateral like this, it's possible that they've had one stroke on the other side and strokes by hemispherically. It is possible, but quite rare to see that. If you see it just on one side, you know that they possibly had a stroke. Another way to do it, if they're unconscious, lying unconsciousness, is to basically to see whether or not, you know, how they basically hold it, one side of their arm. You lift the arm and you drop it down, and the other to see how it flops down. This is all the physician's jobs to assess the patient, but you can get a basic idea of what you're thinking is happening. So just to recap, one is sugar. Don't forget checking the sugar. B, opioids, so medications. 3, seizures. And then 4 is a group that you may find with people that are what I call fake being unconscious. A good way to try and assess what's going on there is to take their arm, and especially these patients that have personality problems, psychiatric patients that are coming in for other issues, you just take their arm, you hold it above their head and you let it go. And if it hits them on they give a good smack on their own forehead, then you know it's probably genuine. But if you feel it kind of does this and does this, or kind of misses the face, you know that it's that there's not a genuine, there's a what you call it, they're faking it, so to speak. Okay, but be careful with that group. All right, but if you do suspect that someone's doing this and just doing it to get attention, particularly with your difficult patient, you can just take the arm and just put. Now, to assess arousability, this is something that you've seen docs do it. I mean, how do you guys assess to see when you're assessing a GCS to make sure that they're truly unconscious or not? What do you do? Do you say, hello sir, hello ma'am? Are you sternal rubbing them at the time? Are you giving them a good sternal rub?
No.
Not at first.
See if they can respond to
If they don't respond to that, then you go to the sternal rub, and if they don't respond to that,
little bed pressure.
what do you do?
Little bed pressure.
Yeah, you just take your pen and just go, if they pull away, and then you know at least that they can have some movement. Okay, good. So that's at least you escalating that appropriately. When do you think a patient needs to be intubated or the airway secured?
So it's supposed to be through GCS 8 or less.
Yeah, so if the GCS is 8, prepare to intubate. Okay, they say in fact if your PCO2 is more than 8 kilopascals, then you also prepare to intubate. Okay, so that's a very good term. Now, there is also a group of patients that you can find that are somnolescent or unconscious, and that is your COPD patients. Okay, COPD patients, and typically what you do is you have patient oxygen, or just put them on a non-rebreather or give them high flow, high percentage oxygen. And then you find that these CO2 patients actually get worse. They call it CO2 narcosis. There are 2 mechanisms there. The one people think is that you take away their hypoxic drive, and they basically stop breathing because it's your respiratory drive is CO2 driven. Eh? So and when you hold your breath under the water, you're swimming and you're doing these things, the reason that need to breathe is not your O2 that's driving it, it's your CO2. So that it's just CO2 that's driving. That's why if you hyperventilate before you, I don't know if anyone's done that, when you can do, they call it a mid-water blackout, where you basically hyperventilate and then you get under the water and then you dive to try to beat your buddies. The problem with that is that your CO2 doesn't get high enough to tell you that you need to go breathe, and then you black out because of hypoxia. So it's the CO2 driving. Now in a COPD patient, they say that they lose that hypoxic drive, but it's a fallacy. It's because of what they have said is that their CO2 climbs is usually higher than normal, and as a default the body relies on the hypoxia, the chronic hypoxia to breathe. Now, and then when you give them CO2, when you give them oxygen, they don't have a CO2 drive, they don't have a hypoxic drive, and then they basically stop breathing. It doesn't drive their respiration. What they really think the mechanism is that you have a lot of dead space in your lungs. So you have space in your lung, emphysema, all those bullets sitting everywhere. There's just CO2 in these, they're called dead space that's not, and anywhere where there's dead space, where there's high concentrations of PCO2 in the alveoli, the vessels, the little capillaries that are lying alongside that gas-filled space, they vasoconstrict, so that the CO2 can't get in and out of the bloodstream. So when you give them oxygen, the partial pressure of oxygen in those bullous dead space increases. And those little capillaries open up, and all that CO2 centralizes into the main bloodstream, and then they get the CO2 narcosis. That's what they think is the real mechanism, not so much the hypoxic drive. So you get a COPD patient that's coming in and they're batting along, and they're having a COPD exacerbation. You do not want to give them high concentration O2. You want to measure the SAT, so 88 to 90 to 92%, no more than that. Okay? if you put a non-rebreather or 100% oxygen with most people, they will become unconscious. So you classically see that in patients. CO2, they come in, you'll find them on they'll go to the ward on their CO2, on their full breather in the ward. You walk in, next minute you find they're unconscious, they're barely rousable, they've got this mask, 100% mask, they're not breathing. Rip that mask off. Rip that mask off and get back there. Or you can just bag them because they're not breathing, but don't use 100% oxygen. Okay, to get back that drive. So be very careful with that group of people. Okay. Now, the only thing that I wanted to just have a few words with is basically falls. And the one thing I wanted to ask with your falls assessment, because I know you guys do this, is that do you guys actually even look at the sodium? Is there any role for the sodium? I just want to point out that if you have a patient with falls, sodium is associated less than 130 is associated with in fact something that's 135 is associated with a marked increase in the risk of fall. So you guys should look in terms of the risk assessment in terms of what their sodium level is.
Are you looking at mentality then? Or how does it affect it?
It's just weakness. I just find that the people that have a low sodium tend to feel quite weak. And then actually, of course, you yourself go and get water intoxicated, so just keep drinking water, you feel that your muscles will get like a little weak, a bit shaky on your legs. And that's because of the hyponatremia. The other thing is I wanted to make sure is when a patient starts to mobilize, when we say mobilize the patient, are you guys doing lying and standing blood pressures before you start doing that? No. So that needs to start to happen. Okay, so I implore the nursing staff in terms of their falling assessment. A, check their sodium. B, if they've been lying in bed and the doc says, oh, that's right, get them to start mobilizing, do lying and standing as a matter of course. Don't ask for us to ask you to do it, okay? That's a lot of things to do, and then I think we would do a lot in terms of our risk falls. People falling, okay? What else is there? Yeah, so the sodium and orthostatic hypertension. Syncope in terms of blacking out and falling and blacking out. The approach there, you find an unconscious patient to determine whether it's syncope versus seizure. Syncope, if it occurs, if they're lying in bed and blacking out, it's cardiac until proven otherwise. Okay. And how you determine it's not a seizure versus, is it syncope or seizure? Is it syncope does not have a post-ictal period. Someone that fits it will be out of it afterwards. They'll be a little bit groggy, a bit drowsy, may have peed themselves, but usually they're usually groggy and a bit tired and a bit out of sorts. You may even think they may be a bit delirious. Okay, syncope, they're as right as rain immediately. They're also not down for a long time. You'll struggle to rouse the post-epileptic patient, whereas the syncopal patient is easily rousable. They'll be out for about 20 to 30 seconds, come out, and have no real recollection of what's going on. If that ever happens while they're sitting or in the bed, it's cardiac until proven otherwise. One is when they're standing up to mobilize and collapsing, it's usually high risk for orthostatic. Also, there's situational ones where they're basically going to the loo and blacking out on the toilet. Those are your situational syncope. So a coughing spell can cause syncope. Taking blood can take syncope. There's all situation ones. The point is to be able to discern whether this is a syncope or is this in fact a seizure or something else. The ones that I want you to be aware of are the ones that if they're blacking out in their chair or they're blacking out on their bed, and that means telemetry. There's a cardiac issue here, okay? And then, those are the predominant causes of someone that you're going to find unconscious. It's up to you to determine what you think it is and to get the necessary help. The ones that you don't want to miss is the opioid toxicity. You don't want to miss the hypoglycemic because that's an immediate threat to life. And that's it, I think. Short and brief, to the point. Any questions? Any experiences? I'm sure you have. Yeah.
When I learned about COPD, they talked about your pink puffers and your blue bloaters.
Yeah.
Okay, oxygen levels when you're administering it affect one more than the other? No?
Yeah, so so your blue bloaters are the ones that you don't want to give them the increased oxygen, but it's very difficult to predict. Yeah, it was a means of them trying to sort out. It depends on how much dead space they have. The blue bloaters are the ones that have become hypoxic, they've got polycythemia, and then they're sitting there with cyanosis. And that's why they're looking all blue and bloated, usually with a bit of core pulmonale. The pink puffers are those pursed-lipped, rapidly breathing emphysematous patients. They both can have emphysema. There's no. They both can have it. So there's really no way to say which ones are going to black out or not. So don't use that as a guide.
Okay.
Anything else, guys? Any other experiences, concerns? As an aside, do you guys put hip protectors on the ones that begin to mobilize that are frail or at risk of falling?
Families have to buy them.
Oh, really?
Mm-hmm.
The families have to buy them? Wow.
The physio department has a few sets, but they'll lend them out just for a temporary basis until the families can come up with the hip protectors from the drugstore.
And how much do a pair of hip protectors cost?
They're nearly $100. James, what are they? What, $85?
I don't know.
And how much does the new hip cost?
Yeah,
More than that.
exactly. Yeah.
Paid for by our medical.
Hmm?
Paid for by our medical.
No, but the question is essentially, as an institution, you should spend the $100 on the hip protector so that you don't have to fix the hip.
You're right.
Yeah.
Family doesn't have to
Absolutely.
pay for a hip.
Yeah.
Family has to pay for the hip protectors.
Yeah, that doesn't make any sense.
Yeah, no, you're right. You're absolutely correct.
How much does a new hip cost?
Cheaper.
Several $1,000s just for the hip. That doesn't include the hospital stay, the rehab and everything that goes on, and the potential complications of actually breaking your hip and getting a pneumonia and all that. So that's completely bananas. They need hip protectors, even on the floor. The hospital should have its own sets
Yeah.
and have them, if they fall and break their hip outside, well, that's the family's responsibility. But you really don't want them to fall
In the hospital.
in the hospital, yeah. It would be ideal if the hospital could just issue them, but the hospital issues them with crutches when they break their leg.
Walkers,
Yeah.
Yeah.
And the hospital issues them with walkers.
transfer belts.
They do, hey?
Yeah.
We have a Red Cross.
So why can't we give them hip protectors?
I don't know.
Bring it up to
We'd have to wash them.
Hey?
Bring it up to VHOP.
Yeah, I don't understand that in terms of cost protection. You know, it's like $100. So not everybody that scores high on the falls risk assessment we should get hip protectors.
That's like everybody.
That is like
That is everybody.
So what's a high score? Like 70,
Everybody.
80 with the Morris Falco, 65.
The question is isn't it related to percentages? So there should be a trend on that score. To say if you score 70, this is the risk of falling. If you score 80, this is the risk of falling.
There is.
Yeah.
Yeah. So I can't remember those percentages.
So like
So you need to discuss which
0 to 30 is low,
30
to 45 is moderate, 45 to 70
70
is
sounds
high, and anything over 70 is fall imminent.
Yeah.
Which a lot of admissions.
So a lot of them are over 70.
Mhm.
I mean, $100. I mean, come on, that's
Yeah.
stay in hospital $700 a day.
Yeah.
That makes no sense.
You're right.
It's really hard to get money for preventative.
You would rather spend thousands for stuff. Okay. All right. That's it, guys.
Thank
Thank you.
Thank you.